Welcome to Your Life is the Medicine, the podcast about the extraordinary power of living a life that heals. I'm Dr. Sonny Miles. I'm a physician and a healer, and I'm so glad that you're here. For over a decade, I've had the honor of walking with people as they navigate serious illness. Not just the symptoms, but the full experience. The quiet fears, the exhaustion of searching for answers, the pain of uncertainty, and the frustration of not being heard. I've also had the privilege to witness extraordinary courage, resilience, hope, and the deep yearning for meaning. And through these journeys, I've come to understand something profound. True healing isn't just about fixing what's broken. It's about creating a life that deeply supports the whole of you, body, mind, and spirit, exactly as you are. This podcast is an invitation to explore a different way of healing, one that honors the wisdom within you. We'll dive into integrative medicine, soulful living, and the practices that nourish your whole being. We'll uncover the unseen connections between your inner world and your body, and we'll ask the big questions. What does it mean to truly heal? How do we live fully, even in uncertainty? If you're navigating illness, seeking a more fulfilling life, or simply curious what it means to heal beyond medicine, you're in the right place. So take a deep breath, grab a cup of tea, and settle in. Let's explore how you and your life can become the medicine that you need. As a reminder, all information in this podcast is for informational purposes only. It is not intended as medical advice. Please seek the advice of your own practitioner for your specific health situation. Welcome to episode 21 of Your Life is the Medicine. I'm Sonny Miles. I'm your host. I'm a physician. I'm a mom. I'm a woman trying to navigate our very complex world while trying to stay well. And so I am grateful to be here, and I am glad that you're here. Today, I'm going to put on my palliative care hat. So as a physician, I am board certified in internal medicine, palliative care and hospice, and integrative medicine. I started as an internist. I worked as a hospitalist, taking care of people who were sick enough to be in the hospital. And then I went back to training, and I did both hospice and palliative medicine fellowship and Andrew Weil's integrative medicine fellowship. And then I worked as a palliative care physician for many years. I still work part-time doing palliative care, and then I also do integrative medicine. And so today I'm going to put on my palliative care hat a little bit. Palliative care is near and dear to my heart, and also a little bit more challenging to talk about. It's less sexy. It's less desirable conversation. I think we like to talk about wellness and integrative medicine and hormone health and all of these kind of bright topics. And palliative care is about showing up for suffering. It's about showing up for pain. It's about showing up when life doesn't necessarily go the way that we thought or the way that we wanted. And so I found it a little bit harder to talk about and to kind of weave into the rest of my work, though it's always there. You can't really separate out the palliative care me from the integrative medicine me. The integrative medicine is blended into my palliative care work, and my palliative care lens is absolutely blended into my integrative medicine work. And so what I want to talk about today, and I'm going to do this in two parts. So today will be part one, but I want to talk about compassionate conversations, about what kind of the conversations that I have regularly as a palliative care physician. And then part two next time will be kind of self-care and how I stay well and how I help other people stay well when we're having hard conversations or when we're doing the work of being a healer. So today I'm going to talk about hard conversations or compassionate conversations. sort of what they are and how I think about them. And my hope is to share them. I am obviously sharing them from the lens of a palliative care physician. And my hope is to make this a little bit relatable, whether you're a healer who has hard conversations with clients, or whether you're a loved one who has conversations with other loved ones, or whether you're just thinking about your own future. And so here we go. I'm going to start by telling you a little bit about palliative care. Many people think of palliative care as hospice or kind of pre-hospice. Sometimes it is, but ideally, palliative care is a specialty of medicine. It's typically an interdisciplinary team, or maybe not typically, but ideally there's interdisciplinary support. So an ideal palliative care team might have a physician or another clinician. Often there are PAs and NPs as part of the team. There are maybe social workers, there may be nurses, there may be pharmacists. And in really ideal teams, there are other health professionals. So when I was a fellow at UCSD, initially, we had a hypnotherapist on our team. We also had a psychologist that was part of our team part-time, and we had a palliative care psychiatrist that was part of our team. Now, I have never been in another setting where we had all of those resources, but the idea is that this is a team that supports the whole patient, body, mind, and spirit, and their chosen family. So it is for people who have serious or chronic illness, ideally from the time of diagnosis until someone either gets better or until end of life and hospice. But palliative care is really about supporting people and their loved ones through health crises or difficult illnesses. And so often in the hospital, that means someone is very, very sick, and we're having a conversation about who they are, what they value, and what kinds of care they want. In the clinic, it may be more about, when I worked in the cancer center, I met people who literally had just gotten their diagnosis of cancer and who were going to recover, and I supported them through the shock and the stress and the crisis of being diagnosed and getting started with treatment. And then there were people that I followed for many years, helping to manage their pain or their nausea or their anxiety or other symptoms, either from the disease itself or from the treatments, and talked about sort of how do you live your best life under these circumstances, and how do you grieve, and how do you keep showing up. And some of them got better over time, and some of them continued to manage their cancer over time and needed ongoing support, and some of them died. And then we talk about how long you want to keep going with treatment, or that even when you want to keep going with treatment, sometimes the body just can't keep going. Sometimes even when there's this deep desire to keep going, it's just not possible. And then we talk about hospice and end of life, and we acknowledge the grief and the pain of that place. And so that's kind of what palliative care is and my experience of palliative care. And I will say that the reasons that I love palliative care is, number one, it feels like truth telling. So often I feel like hard conversations aren't had because they're hard, and because often in medicine there isn't the time or the space, or because people believe that talking about the hard things might take away hope. And we know that's not true in studies. And also people are uncomfortable, right? So many people are uncomfortable talking about hard things. And so to me, it feels like a gift to be able and willing to go into pain and suffering and fear and uncertainty of what does it mean to get diagnosed with cancer, or what does it mean to have COPD, or what does it mean to have heart failure or multiple different medical problems and be in the hospital. What does it mean for you as a person? What does it mean for your life? And so I really value the feeling that I'm giving people truth so that they can make the best decisions for them. And I say that because I really believe that while I hold expertise and knowledge, I am not walking in anyone else's shoes. And so it is me sharing my understanding, my knowledge with my patient or with the person, and them bringing their own values, stories, life experiences to make the decisions. Like, I'm not walking in their shoes. I don't know what's best for them. I try to share what is possible or not possible, and I try to share what I'm worried about and what may or may not happen, but I honestly can't make the best decision for someone else. That's not how it works. And so the truth telling aspect is that I give the best information and share my own experiences walking other people through similar situations, and I help the person I'm speaking with to make a decision for them. So I love it because of the truth telling. I love it because I think talking about what may not happen or talking about the possibility of dying really helps us focus on living. Helps us, and there's always grief and there's always pain. And when we can be with those things, we can also open up the space to say, hey, if my time is shorter than I hoped, how can I make it the best time possible? Or what is really important to me that I haven't taken care of? And so to me, it is the using the lens of mortality to really honor the life that we have or the day that we have, and also to be able to, as much as one can, complete a life, to sort of tie up loose ends so that when death comes, that there is less unfinished, there's less regret about what isn't done. And that those conversations make my life better, right? So there is no way that I could talk to people about these things on a regular basis and not be completely changed as a human being. And so these conversations have absolutely shaped my life and continue to shape my life. And I think the challenge then is actually this balance of life is short and life is long, and knowing when it's important to make something happen because life could be short versus sort of having a vision of, and life could be long, and how do I want all of it to play out, right? If I only think about life as short, like you only live once and you do all the things, but you're not caring for yourself in a way that promotes longevity. And that's where sort of the integrative and palliative care come together, is this like being present and having a vision of what do I, if I am lucky enough to live a long life, what do I want the arc of that life to look like? And how do I care for myself so that I have the greatest health span over time? And so that's what I love about palliative care. Now, some of the conversations, I want to share some of the types of conversations that I have as a palliative care physician that you may have had or may have in the future, depending on your journey, whether it's a journey of illness or a journey of just aging. These conversations happen for most of us at some point. And so the types of conversations that we have are, one of them is the conversation of how much longer do you want to keep going? And this is a conversation of quality of life versus quantity of life. And I'm going to come back to that. Other conversations are sort of about, what does quality of life look like for you, and what's a tolerable quality of life, and what would be an intolerable quality of life. Other conversations focus around specific interventions, like if you if someone has a stroke or they have often with later stage dementia, people are not swallowing safely, or if they have a stroke and they're not swallowing safely, would this person want a feeding tube, either temporarily or permanently, for artificial nutrition or for nutrition? So, conversations about specific interventions. Similarly, in the intensive care unit, we're talking about if somebody would want to be on a ventilator if they couldn't breathe on their own, or if they would prefer that we allow them to die rather than put them on a ventilator. Or if someone's loved one is already on a ventilator but isn't getting better in the kind of the timeline that we need them to, then are we talking about stopping the machines and allowing someone to die as comfortably and as peacefully as they can? Or are we talking about permanent, like a tracheostomy or a quote unquote permanent breathing tube to allow them to recover more slowly over time? And obviously, different clinical situations, like some clinical situations, a trach is clinically appropriate because we think that the person may recover over time. Other situations may be that we don't think they're going to recover over time, and so we wouldn't actually recommend a tracheostomy because that would feel like prolonging suffering, perhaps. And so we have conversations about very specific interventions and whether someone would want them or not. And to be clear, sometimes these conversations are with the person, and sometimes they're with their medical power of attorney or their medical decision maker or their families because the person themselves isn't able to participate. So we have conversations about specific interventions, and then we have conversations about sort of the bad news of, unfortunately, we have done everything that we can in medicine and someone isn't getting better. And unfortunately, we are at end of life. And we talk about what end of life looks like. And we talk about hospice, if that's appropriate, if there's time to get someone either home or to a inpatient hospice unit. And so providing education and support around, like, what does dying look like? Because many people have their exposure to death and dying is through Hollywood, and death is often much quicker, or it's not, it's fabricated, right? Like the dying experience for many people is often over many, many days rather than just like somebody very quickly and peacefully dies in the movies. And so we talk a lot about what does dying look like? What do we expect? How do we make sure someone is comfortable as they die? So these are the kinds of conversations that I have as a palliative care physician. And so one of the things that I think is important for everybody to think about and talk about over time is quality of life. Like, what does quality of life mean to you? And I will first say the other thing that palliative care often talks about is is thought of as like the paperwork. So your medical power of attorney, do not resuscitate orders, living wills, things like that. My own personal opinion is that the most important thing you can do is to have a medical power of attorney, to have a medical decision maker, and to have conversations with that person over time in an ongoing manner about what you do and don't want. So often we get living wills or advance directives that are legal documents made by lawyers, and they are sometimes helpful as a guideline, but they very often don't fit the actual clinical scenario that's happening in the hospital. And so it is helpful, but not as helpful as you would think sometimes. And so again, this is why I say that I think the most important thing is to have conversations over time about who you are, what your quality of life is, what you value with your medical decision maker, so that you can have your paperwork, but they also have conversations about how you're thinking about your quality of life and what would matter most to you in various situations. And so when I talk about quality of life is an individual definition. Your quality of life, your definition of quality of life and my definition of quality of life may not be the same. It also changes over time. And so one of the ways that I often explain it in the hospital is that I have met people who tell me that they want to, if they're living in a facility, if they're living in a nursing home for the rest of their life and they're bedbound, but they can still eat and watch TV and talk to their family, that's good enough for them. And that would be an okay quality of life for them. Whereas I have met other people who say they never want to be in a facility, that if they can't go to the bathroom themselves or, take care of themselves, that they wouldn't want to be kept alive. And I have met other people who have said, like, if I can't go play golf or I can't go to the mountains or I can't get outside and do things, I don't want to be kept alive. And so each of us has a very different definition of like what an okay quality of life is. Now, the other important point is that that definition changes over time. So that person who was very healthy, who said, like, if I can't play golf, if I can't go to the mountains, like, I don't want to be alive, suddenly they have a new diagnosis or something happens and they can't play golf, but they're enjoying reading and being with their family and getting to go on shorter outings. Their quality of life definition has changed. And so I think it's really important that, again, this is why I say these conversations need to happen on an ongoing basis, because what is important to you now may not be important in a year or two. Like you may have changed kind of what matters, because we're humans and we grow and evolve over time. And so what would be acceptable to you as a quality of life? And we all hope that we are healthy and well and caring for ourselves until the end of our life and that we would die peacefully in our sleep, right? Like that's what so many people wish for. And we can hold that hope and we can work towards like long health span, while also making sure that if something happens, our loved ones know what we want and that we are taken care of in the way that we want. So it's the duality of we want to live long and healthy lives and things happen, and we want to make sure that we understand your wishes and your family member understands your wishes and that you get the kind of care that you actually want, that aligns with who you are as a person and your values. So that quality of life is sort of the biggest kind of metric that I use in my conversations, because even in a conversation about how long you want to keep going with treatment, whether someone's in the ICU or someone's getting chemotherapy, is about sort of what is your quality of life and what do we expect your quality of life to be after this illness. And so many people go through an illness and go through a lot of suffering in order to have a better quality of life on the other side, right? We think that if we go through the suffering of being in an intensive care unit in order to get better and get back to our life. And at the point that we worry that you can't get back to your former quality of life, then we have to ask the question of, do you still want what we're doing to you? And so it is like, what was your quality of life? What do we expect your quality of life to be on the other side of this? And what's a tolerable quality of life to you? And so that is like the core of every conversation, is quality of life. Because then we get into the conversation of quality versus quantity of life. And many of the things that we do in medicine are to prolong life, to give you greater quantity of life. We want to make sure that not only do you have quantity of life, but it's a quality of life that you want. And so that's always kind of the balance and the ongoing discussion of, are we focused on quantity? Are we focused on quality? Do you have enough of both? The other thing I want to say about these conversations that is important to me is how we have these conversations. So, as you can tell, many of these conversations are hard. Many of these conversations are not things that anyone wants to hear. And yet, sometimes people have been feeling that things aren't going well, and no one has said that to them out loud. And so, actually having the conversation, while painful, can bring a lot of relief that what they're sensing or feeling is true. And so there's also freedom in making decisions. There's freedom in having information about what decisions can be made. There's freedom in knowing what hospice is and what hospice offers when the time comes that you need to know about hospice. And so these conversations, they bring or make space for the grief and the pain of illness, of end of life, of whatever is happening, and they can also give some freedom and some ease. When I have these conversations, it's very important to me to pay attention to people's sort of nervous system regulation and safety, because we all have different experiences of trauma, and especially many people who have chronic illness or who have had multiple episodes of medical care have medical trauma. And so it is important to me to be aware that everyone in the room has a different experience with health, with wellness, with illness, and with the medical system, and then their own sort of life experiences and life traumas that affect how we cope and how our nervous system is primed to react to difficult and painful things. And so part of what I'm doing when I'm in the room is trying to make everyone feel as safe as they can in a healthcare setting, and paying attention to how much information people do or don't want, and often explicitly asking permission. Like, is it okay if we talk about, or is it okay if I ask you a very difficult question? Because I want people to feel that they have power in the conversation. I don't want to feel like I am dumping hard things on them or pushing hard things on them when they don't feel like they have the capacity to receive it. And I think I'm thinking I had a therapy appointment once where the therapist started to say something, and then she caught herself and said, "Do you want to hear something hard?" And I truly wasn't in a place to receive it, and I said no. And I appreciated that. I appreciated that she asked, because many other times in this particular dynamic, I had felt like I wasn't seen. And in that moment, having her ask gave me some of that power back. And so it is very important to me to try to give people in the room their power to make their own decisions and to choose how much they receive. And this also goes for like how much of the conversation we have in one day. So it might be that we spend an hour talking through many, many, many things. And it might be that we just get through the hardest first part and we leave the rest for another day because it's too much. And so really honoring people and where they are and what their capacity is to have a hard conversation as much as possible. Sometimes there are hard decisions to be made that need to be made in that moment, and we don't have the same luxury to go several days, but as much as I can, honoring everyone's needs in the room. The other thing is, these conversations have taught me about grief and how grief illiterate we are as a society, and how often grief goes unnamed or unacknowledged, and how much grief there is in illness. And it's not just grief of dying, but grief of all of the things, the grief of not being able to go back to work, of not having the same role in your family, of your body not working as well. And we often think of grief with big diagnoses like cancer, but something that is a more chronic, manageable disease like diabetes, like a new diagnosis of diabetes or a new diagnosis of high blood pressure, might also carry a lot of grief or trauma for you. And so really being aware of and acknowledging the grief that is coming up, because many of us don't have a vocabulary or an awareness around grief for all of these. I'm going to use the word smaller. It may not be the best word, but all of these other types of non-death grief. We have language around big losses like divorce or death or, a pet dying, but we don't have language around the loss of function, of aging, of loss of autonomy, of all of the little losses that accumulate over time. And so being aware of and naming grief and the importance of grieving is really important to me in these conversations. And then I want to end on resilience. So we've talked about what palliative care is, talked about the kind of conversations. I'm telling you that I want you to name your medical power of attorney. In Colorado, that is a document that does not have to be notarized. It's just signed by you. Other states are different, but naming a decision maker and having a conversation with them about what quality of life is to you and what your values are. And then we talked about trauma and grief and safety and power in the conversation. And I want to talk about resilience and what I've learned about resilience from these conversations. There are moments when something is new and hard that we just need to be in the grief and the pain and the suffering. And we get to feel how we feel and we get to cope how we cope. And beyond that, the invitation is how do we keep living? How do we keep going? How do we make life the best that it can be while still acknowledging the grief? I'm not advocating spiritual bypassing. I'm advocating holding, honoring, moving the grief and the pain. And how do we live the best that we can? How do we love? How do we laugh? How do we be in the moments? How do we be our whole human selves? And to me, that's part of what resilience is being with what is hard and choosing to honor what is hard and to keep growing, to keep loving, to keep laughing. And one of my favorite resilience stories is, and I may have already told it before, but I met a man in the cancer center who was elderly and who was a singer, still a musician, and he had head and neck cancer. And we were talking about, the treatment for head and neck cancer, which is often chemotherapy and 6 weeks of radiation. It's a very intense and difficult treatment regimen. And we were talking about his hopes to get his voice back and be able to sing again. And he said, but if I can't, then he'll just become the best guitar player he can become. And to me, that's the resilience, right? It's hoping that you can get everything you want and saying, I'm still going to live even if I don't get that thing that I want, that I'm going to honor the grief, I'm going to honor the pain, and I'm going to keep going. I'm going to find the beauty, I'm going to find the joy, I'm going to find the meaning, even if it looks different than what I want it to look like. So thank you for listening to this. I'd love to hear any thoughts that you have, any experiences with hard and compassionate conversations, or compassionate ways to have hard conversations. Maybe that's a better title. And anything that this stirred up for you. So definitely leave it in the comments. And I hope you have a wonderful rest of your day. Thank you for joining me on this journey of healing and discovery. I hope this episode has inspired you to see your life as the medicine, a powerful source of wisdom, resilience, and well-being. If you enjoyed today's conversation, please subscribe to the podcast and leave a review. And be sure to share it with your friends and family who might also benefit from this message of hope and healing. To learn more about my work and access additional resources, visit honoringthewisdomwithin.com. If you're in Colorado and interested in my integrative medical practice, you can find me at healingwithintentionim.com. You can also connect with me on Instagram at Healing with Intention I Am. Until next time, remember, your life is the medicine. Embrace it, nourish it, and allow it to guide you on your own unique path to wholeness.